You're listening to the UBC Medicine Learning Network.
Hello everyone, welcome to Metamorphosis. My name is Dan.
And I'm Tina. Here on Metamorphosis, we are interviewing various physicians across BC with the aim of learning more about their specialties to help us navigate our medical careers. We have a very special guest joining us today, Dr. Peter Choi from Anesthesia.
Hi, my name is Peter Choi. I'm an anesthesiologist at the University of British Columbia in the Department of Anesthesiology, Pharmacology, and Therapeutics. I am a clinician that practices at Vancouver General Hospital and UBC Hospital, and I'm involved with the MD undergraduate program with the medical school.
Welcome, Dr. Choi, and thank you for being on the podcast with us today. Could you just start by telling us a little bit about your background and how you got into medical school and kind of your journey?
I think I've always been interested in medicine right from, according to my parents, grade 3. And so when I entered university, I decided to pursue biology with the thought of trying to get into medical school. I was fortunate and got into medical school here at UBC. At that time, I really did not have a good idea of what medicine was like. My initial impressions were based on encounters with my family physician, and the first thing I thought I would become was a family physician. So I did actually all of my clinical electives in family medicine and discovered that that was not the area of medicine that I was interested in. At the same time, I worked as a research assistant in the mood disorders clinic here at UBC while I was in medical school. And so I was exposed to a lot of psychiatry. And then the other thing that I was interested in was internal medicine, partly because my preceptors gave me very positive support about it, and I found solving problems was very interesting. So by the time the CARMS came along, I was trying to decide between psychiatry and internal medicine. And culturally, my family was not very supportive of me going into psychiatry. So I chose internal medicine. Part of that's also by serendipity, because back then, the write-ups for internal medicine across the country for the residencies, most of them looked almost identical. And the only one that was different was the one at McMaster University. And because of that, I put that as my first choice. I had a few rotating internships that I picked, and that was the only place I went for an interview. And I got into internal medicine. So I wasn't in anesthesiology initially. In fact, my early impressions of anesthesiology was all negative. We only had 3 afternoons in the rotation for anesthesiology. And back then we were assigned to a single hospital. I was in BC Children's, which meant that it was really difficult to do anything. That's because with kids, they desaturate really fast and your staff person intervenes right away. So there was not a lot of chance to gain any skills. When I entered residency, if you had told me I was going to be an anesthesiologist, I would have laughed. But unfortunately, or fortunately, very early into my internal medicine residency, I realized there were certain aspects of internal medicine that weren't ones I enjoyed. And the things I really enjoyed were the acute management of disease. I liked technical procedures. And then because anesthesiology residents also do internal medicine rotations, the ones who were rotating along with me were telling me how great anesthesiology was. And so as I was thinking about what I wanted to do, that was one of the things. that I thought might be a possibility. And in my second year, I decided, you know what, I'm still going to take all the internal medicine rotations that I need for anesthesiology, and we'll see what happens. And by then, I had told my program director in medicine that I wasn't going to continue for a third year. And I had made up my mind that if I could not get a position in anesthesiology in Hamilton, then I'd have to find some other way. Fortunately, I got the position. I ended up in anesthesiology, but that's how I started anyways.
Sounds like along the way you sort of took some twists and turns and changed your mind. I think maybe just going back to that first change that you made when you were thinking family medicine and then went away from it. What was sort of going into your decision to feel like family medicine wasn't right for you?
That's a great question. And I think, I was in sort of the position you folks were in terms of trying to figure out what I wanted to do. And back then we didn't have the fancy software-based questionnaire that you can take to look at what your personality, your interests and all. It was all on paper, and then you had these little index cards that you go through. And for me, it largely was that my initial impression of what a doctor is a family doctor. And I think that certainly for the curriculum, that's what we're trying to give you the skills for, to be someone who can be a generalist. And I have a lot of respect for my colleagues who go into family medicine because they are basically a front line and they do the primary care. But when I was doing my electives there, the thing I noticed was there were a lot of patients who came in and they would have health problems that they enjoyed speaking to the physician with, but that readiness for change was not there. So an example would be one of the patients that I saw as a medical student was a woman who came from her car accident. She had a rear ender to the family doctor's office. I don't think nowadays you could get an appointment that quickly, but back then she literally had the thing, called the family doctor, came. And so with the supervision of my preceptor, I was explaining to her, well, these are things you want to do to ensure that you don't continue to have stiffness, exercise, physio, things like that. And we said we would see her in a couple of weeks. 2 weeks later, she came back and she had not done any of the things that have been recommended. And now she was very stiff. And I found that intensely frustrating that why do you come if you're not good? And I realized it takes a certain kind of person to be very patient and not feel like this is about me. At that age, failure of someone to do something for me felt like it was me. And now looking back, I can realize, that was probably part of the reason why I didn't enjoy it. And there was also a lot of paperwork that family physicians do. And it seemed like it was a lot after hour of that. And neither of those things were things that I found appealing. I think if I had actually done a rural rotation, my viewpoint may have changed. But when I was in medical school, not everyone could do a rural rotation. Now I think all of you have some time in third year for this. Back then it was a bit of a lottery whether you got to do it or not. So that's part of the reason I think why I changed. The other thing I realized as I became more senior as a medical student was there were some things that I just found much more fascinating. And suddenly family medicine wasn't the only aspect of medicine that there was, which I didn't know when I went into medicine.
Maybe if you can think back to sort of around that time when you decided for sure anesthesiology, for you, was it sort of a very rational pros and cons list where you sort of weighed both and decided, yeah, this is a good fit for me? Or was it like an emotional surge where you just realized that this was your calling?
It was colored by a number of things. And I think anyone who's at that stage where they're thinking of changing, especially in residency, there's a lot of soul searching because, you you take so much energy to match in CARMS. And, I know everybody gets super excited or nervous on CARMS day, and you got in and you think, this is what I'm going to be. And to discover that maybe this is not the right choice, it's really hard to make. It took me, a while to come to the conclusion that I was not going to continue internal medicine. What I was going to do was still a little bit unknown. And in fact, I wasn't sure about anesthesiology, but the things that I was looking at, first of all, when I was doing rotations in critical care, the anesthesiologists who did critical care medicine were always jumping in and doing things. They seemed to be very good at doing the procedures, and they jumped right in. I noticed that it was quite different from the practice of a lot of internists who would round with you, and then they had clinics or office things that they had to do, so they weren't as present. Maybe that was just the circumstances, and not trying to diss my internal medicine colleagues, but it was just something I noticed. And in the operating room, the anesthesiologists just seemed to be they were always very calm and just got things done. But they were exciting things, you get to make people, if there was a resuscitation needed, it was sort of an anesthesiologist coming to help you out. It was always just very reassuring. But whether that was the right thing, I remember going into the interviews for the anesthesia position, and when I was asked that, I said, why do you want to? My answer, and it was, I just want to. I think this is the right thing. I had no good rational reason aside from these impressions that I had. Now, also, I redid that questionnaire and thought, well, it sounds like it's a better fit than internal medicine. But, I was taking a big gamble. Some of the other things that colored my view was when I was in internship, I married my fiance, and we had been together for 6 years before that. So we thought, we knew each other quite well. But that first year residency, I was spending so much time as a resident working that the marriage very quickly was deteriorating. So I had to make a decision that I have to find something where the lifestyle is compatible with, it's either that or divorce. And that was the best decision I made, is not to go that route and to rather change what I did. And so that colored in a way also my choice, because the lifestyle of an anesthesiologist, at least looking at the preceptors I worked with, the people I looked up to, was better. All the internists that I looked up to all seemed so busy with research and clinical practice, and it was a bit worrying to me, because many of them were, the ones that I looked up to were either divorced or single, which wasn't the category I wanted to be in. Yeah.
So as you said, it was a pretty big risk changing it, and switching from one residency to another is kind of a delay in time and in your career, and really a lot of the things that come afterwards. Do you regret that decision at all? Like, do you wish that you had known from the start that anesthesiology was the thing for you and that you had pursued it? Or do you feel like you learned a lot from internal medicine and it was worth taking the roundabout route?
I have no regrets. I can say that with confidence. I think what I gained from internal medicine is I still love some of the problem solving, this clinical decision making that you see. Typically the sort of things that you see in medical school that they're trying to convey to you is very much from an internal medicine perspective. And I still love that problem solving. I love being able to make a diagnosis. I don't do that as much now. And I actually enjoy talking to patients, which is kind of funny because we don't actually speak to our patients very much except in our consultation clinic. But I enjoy that. So, and the skills I learned in medicine were still put to good use in anesthesia, but they were in a different context. So I'm looking at people for a very short period of time. And what my job is to ensure that their medical problems are as good, as well taken care of as they can be before they come for surgery and anesthesia. And so understanding the medicine is still really helpful. And my particular interest in anesthesia has been in the perioperative medical realm. So there's a subset of us who like doing what's called perioperative medicine, which is the care of patients around the time of surgery, prior to surgery, during surgery, and then usually within the first 30 days of surgery. So my area of research has been in that. So it certainly has colored what I do. What I do miss is some of that patient interaction and the relationship. I don't miss the long list of people that you have to look after, or some of the more social work aspects of figuring out beds and other things. So those parts I don't miss. And in my field, compliance is usually not a problem. And that was another thing that as I said, I struggled a lot with non-compliance.
Could you expand a bit more on the patient interaction point? Because I know that's been something that a lot of people thinking about anesthesiology have to weigh. How would you describe your interactions with patients and maybe the enjoyment that you get out of it and maybe the frustrations too?
So I really enjoy the preoperative assessment. I think that's my chance to act. The challenge in anesthesiology is you have a very short time to establish rapport. Right? Often when we're seeing these people, they are not at their best. And they are also, especially if the first time they see us is just before surgery. Right? So we have to find ways to lighten the mood, present confidence, and at least explain to them how things are going to turn out and give them a realistic expectation of what we can do. At the same time, hopefully, being able to give them some confidence that things are going to turn out well. So I enjoy taking the history, I enjoy doing the physical, and then chatting about the plan with patients. The other things that sort of give me satisfaction is after they wake up, being able to go back and see them and see how they're doing. So, and every person is different. Some people want more, some of my colleagues want less to do with that. Some of us want more. So that's why I like working in the consultation clinic. But the things that I learned to give up is if you do your job right, most people will not remember you. And most people will not thank you for what you do, because the person they'll remember is the surgeon, right? That's the person who fixed their problem. We're really in the background saying, we are keeping them alive. We're trying to get them either to be back to what they were before the operation if they were healthy, or we're trying to make them better if they're coming in critically ill and we're doing something to try and make them better. But that sort of thing is done without the patients usually knowing about it, right? And so if you're wanting a long-term relationship where you get acknowledgement and you're in the spotlight, then anesthesiology is not the right place. It's really feeling that I get the job done and being able to be aware for myself and pat myself on the back and say, today you did a good job.
Maybe just a quick follow-up question for people who maybe don't know as much about the day-to-day flow of an anesthesiologist. Mm-hmm. Maybe if you can think for an average patient, how many times over the course of their surgery would you see them and interact with them? And about how long would those interactions look like?
So, so if a person is healthy coming for an elective procedure, they may or may not have a chance to interact with the anesthesiologist outside before surgery in terms of like going for a pre-operative appointment to get a formal assessment. Okay, we used to do this all the time, but with the way healthcare has moved, we realize many people don't need to be seen by a doctor days before surgery. They don't need to come in the night before to be admitted. So many people, their first experience is just when they're in their hospital gown, an hour or so or to minutes before they're going into the operating room. And they'll meet the anesthesiologist we'll have a chat. And I have to admit, those kind of interactions are usually 15 minutes or less. So that's their first impression. The next time they see us, they're on the operating table. And the typical stereotype is they'll see this mask drop down over their face, and then if they're getting general anesthetic, and then they won't recall anything until they get to recovery room. And depending on how healthy or unhealthy they are, they may or may not see the anesthesiologist ever again. It'll be their surgeon that they'll see. So our time is actually very limited. Okay, if they're doing something that isn't under general, then they would be spending time, like we would be keeping them company and watching over. We're always in the room. It's just that they may be aware that we're around. But even then, most people have sedation, and so they don't even remember that we're around there. Yeah. So as I said, it's a different interaction. It's certainly not the kind that you would get on a ward where you have a lot more time. The other time that they might see us again is if they are using some of our pain management modalities. So then we would round on these pain. For instance, if they had an epidural in for pain relief, we would come by and see them after to make sure that their pain relief was adequate, there are no complications. And so that might be the other time that they might see us again.
I know you talked about before that your decision to go into anesthesiology was in part colored by sort of your relationship and lifestyle factors related to it. I wonder, do you have any advice to offer medical students who are feeling that pull between maybe interest in the medical field and considerations of their lifestyle, and how to navigate sometimes those very opposite goals at times?
Again, that's a really good question. Some of it will depend on where you are in your relationships, right? If you've been in a long-term relationship, you and your partner probably know each other fairly well. And then I would say that the decision-making process of what you want to do will certainly, it's best if you involve your partner in thinking about what this might mean in terms of your life, okay? If you are not in a relationship, then it's really what you want to do. The challenge is going to be, will your partner be able to follow you into what you wish to do? And so how important your relationship is, depending on where you are in your stage, is going to will need to be taken into account. When I decided to go into internal medicine, I was engaged, but I wasn't married yet. And one of the difficulties my wife had when I proposed was I told her I was moving to Hamilton. And neither one of us had ever been to Hamilton. And she really had to think about that, about, do I really want to move? Because we both grew up in Vancouver, did she want to uproot, leave her family, and move to this city she had never seen, and leave her job? So those are some of the considerations you have to put into it.
For myself personally, I want a job where I'm not looking at the clock and counting down the minutes. I want to be in love with my career, but also able to explore the other things in my life, because all medical students, we have interests outside of medicine as well. And so taking all of these things that you've mentioned into consideration, is there one thing that you would give the most weight to? Or are you kind of a fan of pros and cons and looking at everything as a whole?
I'm the latter. I think there in medicine and in life, there's always give and take. And some of those values will change over time too, right? And so when I make a decision, I have to look at all the various things that I feel may be important to me, and then have to figure out how much of which am I willing to give up or put on hold, and what are the things that I must have. So as I said, for me, the relationship with my wife was not one of those things that were going to be negotiable. And then when we started looking at me changing into anesthesiology, one of the things that had been suggested was that there may be positions in Ottawa and Winnipeg, which happen to be very good programs in anesthesiology. And my wife had basically said, I have a job here in Toronto now, and that's not negotiable at this point in time unless we move back to Vancouver. So again, that was, to me, location wasn't an issue, but for her it was. And again, that also highlights, because one of the values is relationship was important for me. Other people may find that, you may say, there are certain things I want to continue to do in my life, and they may not be compatible with some of the expectations in whatever field you're in. And I can't think of any off the top of my head. Residency is always about trying to balance those things, and then once you get into your career, again, it's a new balancing again, because you, in a way, you have some control how you set up your practice, and in other things you don't. In anesthesiology, the challenge, one of the drawbacks is you don't have as much control of when you work. We work in a group practice, we're located in a hospital, the number of people that are needed are dictated by surgical wait lists and availability operating room. You can't just unilaterally say, I'm going to take time out now. You have to look at the considerations of your department. Whereas if you chose to be just working in, for instance, let's say walk-in clinics or doing locums, you have a lot more flexibility, for instance. Now that's an extreme example of the opposite of what it is. But those are some of the things that, you have to think about. It might be things you are very good at that you don't want to give up. And maybe deciding, can I still pursue this while I'm in residency and career? Do I need to change how much I do of it? Or do I need to put it on hold for a little bit? Those are things that you consider. So I can't think of any one particular thing that I would say this is the line that, this is, if I don't have this, then it's a no-go for me, aside from relationships.
It sounded like you did that with your wife. You had that negotiating process where you were both negotiating what each of you valued and how you're going to go forward.
Yeah, I don't think we were as intentioned as I described it. It was probably messier back then, and but yeah, that was looking back. Yeah, that is essentially what we did.
Could you discuss what your job entails, what the job of an anesthesiologist is, and what your day-to-day looks like?
Sure. I'll preface that because I'm full-time faculty, I would say that I'm not quite representative of what the typical anesthesiologist does. But in terms of what I do, an anesthesiologist, and anesthesiology is really the practice of providing perioperative care for patients, okay? The public sees mostly us as the people with the mask on who take care of them during the operation. But really, the time that we care for is ensuring one of the big questions you always try to teach our students is this person as good as they're going to get before they come into the operating room for surgery and anesthesia? Because bad things can happen, and so we want to minimize it. So it's about trying to get people optimized, as we call it, and also determining what are the level of risk that they undertake when they come for surgery and anesthesia. And then after surgery, how can we follow, and during and after surgery is what can we do to try and mitigate those risks. We focus a lot on cardiovascular and respiratory systems because a lot of what we do entails that. And the other things we are very obsessed about is pain, so pain management, and also postoperative nausea and vomiting, because that's usually an iatrogenic complication caused by some of the things, the drugs we give. Our practice entails a lot of maintaining homeostasis. So we rely a lot on the foundations of pharmacology and physiology, And I like to tell students that every person we look after is like a one-person lab in pharmacology and physiology. So we get to know our patients, but in a perverse way, not by talking to them, but watching what their body does in response to the operation and to the things that we do. And every person is different that way. So it's a kind of a strange way to look at human beings, kind of like pathologists see human beings. So we are more looking at, we get to know their physiology and a hint of how they metabolize drugs and handle certain stresses by spending time with them. So it's really a specialty that deals a lot with physiology, pharmacology, monitoring, risk assessment, and being experts in managing the airway and experts in dealing with acute pain. So the typical anesthesiologist would be someone that's based in a hospital, and you would usually work, if you're full-time, you're looking at, a 5-day week schedule, working in the operating room. You would have your turns to be on call at night, covering emergencies, or looking after the needs of pain management needs, for instance, of pregnant women. And basically, you see the patients in the morning before your surgery. You take care of them in the operating room. You hand over to the nurses in the recovery room, and you repeat until your list of cases are done. And you usually spend the day with one surgeon and a team of nurses. So it is very much a team-based approach now, especially in Canada. We're much more collaborative in some ways than other cultures. And so, but it's sort of this cycle of just constantly doing the same thing. But when you leave the hospital, your day is done. When I was in internal medicine, one of the things I noticed is when I left the hospital, I'm still thinking about my list of patients and what is that diagnosis, or I got to remember to follow these blood work, or I've got to arrange this investigation tomorrow. Whereas for us, when we finish a day, we're basically going, assuming we've done our job and we've handed over and we're comfortable with the status of the patient, that's it. And then the next day is a new day, sort of thing. You might get an opportunity to go and follow up on someone if they're admitted after surgery, like to check on how well they're doing from a pain perspective. But there's not much more to the relationship. So the bad thing is no long-term relationship. The good thing is when your day is done, it's done. You don't take your work home with you. So that would be a typical sort of setting of the clinical practice of anesthesiology. In an academic setting, there's other things that you could add on to it, which is what I do. Yeah.
I've heard the expression that in anesthesia, there's sort of, you're either at 0 or you're at 100, and you have sort of a very keeping things going, or you have a very acute case. Do you feel that that's an accurate statement, or what do you think about that?
I think that's a fair statement to make. One of the sayings is that it's 90% boredom, 10% sheer terror. Another analogy that I use is that in our specialty, the things we do are very much like pilots. So we rely a lot on quantitative data to make our diagnosis, as opposed to, because our patients are asleep and can't tell us things. Most of the time, getting a patient off to sleep is a time that has some risk. So it's like the takeoff of a plane. You get into mid-flight, and most of the time, if everything's going well, it's quite boring for a spectator who's not an anesthesiologist, saying, you're just twiddling your thumbs, looking at a bunch of little bips going across your screens. And occasionally there might be turbulence mid-flight where something happens that you need to do something about. And then the landing is the hardest bit, where waking someone up as they emerge from anesthesia. And so if you continue that analogy, you can say there are times when you're really like a bush pilot, where you're just flying short distances and there's not a lot to go on. So those really fast turnover cases where things are happening all the time, so there's no time to stop. or you could be on a long transatlantic flight where it's a very long case, such as a spine operation or a neurosurgery, where things are usually pretty stable during the case and it's only the induction and emergence. Or you could be a jet fighter pilot where the whole case is about trying to keep from the patient crashing. And so depending on your personality and probably the stage of your career, you get attracted to certain things. Some of my colleagues are real adrenaline junkies, so they go into the subspecialties of medicine where there's always these acute things going on. Others are prefer a more calm environment. And most of us, as we get older, also go, if it's a boring day, it's a good day because there's less complications going on, things are running well. We're no longer, well, at least for myself, as I age, I'm not looking forward to seeing unexpected events. Medical students love it. When they shadow me, they love seeing when something unexpected happens because they then see how you actually operate in that field. But for most of us, it's going like, well, we're not seeking to have these things happen. So that's sort of the analogy that we would have about anesthesia. So yeah, there's some truth that it can be very boring, like looking like it's 0, and then all of a sudden you're at 100 sort of thing.
Can you expand on what subspecialty options there are in anesthesia to sort of go one way or the other in terms of that experience?
So I think the profession is a good gateway to a number of different things. So typically in any specialty, there are going to be subspecialties. Like internal medicine, there's a lot. And in anesthesia, we have subspecialties depending on the system. So for instance, if there's cardiac anesthesia, so there's people who will take extra training to be able to give anesthetics for patients who are undergoing heart procedures, either open heart or not. And there are formal fellowships for that. If they're doing, there's thoracic anesthesiologists who are basically ones who have an extra training in anesthetics for people who are having lung resections and resections around that in the thorax. There is neuroanesthesiologists who basically focus on the CNS, so surgery of the brain or the spine. We have people who do regional anesthesia, so they're very good at sticking needles and injecting local anesthetic into different nerve plexuses and things like that. We have those who specialize in kids, pediatric anesthesia, and those who specialize in pregnant women and the issues that can happen with them, obstetrical anesthesia. So those are some of the things that are there. Then there are some more academic fields. You can specialize in medical education. You can specialize as a clinical epidemiologist, which is what I did, in terms of like research and that sort of thing. There are now, extra people who pursue medical leadership opportunities and formal training in that. So those are sort of non-clinically related subspecialization you do. There are other things that anesthesiology allow you to go into because of the skill set we have. In some countries, that's the route into critical care medicine. In North America, it's one of the routes into critical care medicine. So there are colleagues of mine who are anesthesiologists who do a year or two more of critical care medicine so that they actually work in intensive care units. Because we deal with pain in our specialty a lot, some of my colleagues have subspecialized in management of chronic pain. So not the pain from surgery, but people who have long-term pain that need slightly different solutions. And then there's the field that I sort of focus my academic interest in, perioperative medicine, which is an emerging field, where you're looking at the patient across the entire spectrum from pre-op to post-op, but we're really looking at it in terms of reducing the risks and adverse events in that field. So it's a combination sort of internal medicine, various specialties of internal medicine, anesthesiology, and surgery itself. So it's really fascinating because it is a multidisciplinary area where nobody has sort of decided to sort of say this is our territory yet. So in that way. So those are some of the things that you can branch out to.
So anesthesiology is also a +1 option for those training to be family doctors.
Yes.
Could you talk a little bit about the differences between the two streams and what they're able to do? Sure. And where they can work?
Yeah, and so the +1 option in anesthesiology is really, at least in BC, is designed to identify people who have an interest in the delivery of anesthetic care in communities that are going to be smaller with sort of less resources. So in BC, they're generally smaller communities because most of the big cities, you have to be a Royal College trained anesthesiologist. So I have friends who are GP anesthesiologists in places like Terrace, Vanderhoof, some of the smaller towns where you may not have the acuity or the caseload that would allow a Royal College anesthesiologist to maintain their full skill set. So the difference between that year and a 5-year Royal College thing is that in 1 year, you can learn how to provide safe, competent anesthetic care for patients who are fairly healthy. So with maybe minimal comorbid conditions that are well controlled, and give those anesthetics for what we call like sort of bread and butter surgical procedures, the procedures that would be done even in small communities. It does not give them the competency or the comfort level to handle the rare kind of conditions that patients might come in with, the more subspecialized procedures, or the extremely sick person, aside from if this was a true emergency. So in those communities, you wouldn't see someone who had a lot of comorbid conditions who needed specialized care afterwards come in for an elective procedure, both partly because the hospitals wouldn't have the resources, and you wouldn't have people who are comfortable looking after them. And I'm not just talking about anesthesiologists or surgeons, but you have to have a whole team, nursing care and things like that. So that 1 year gives them that. And as a specialist, I'm supposed to be able to handle those settings and have at least a good foundation of all the various subspecialties. I may not be a subspecialist, but if push came to shove, I should be able to at least give a credible, safe anesthetic for in these rarer things. The pluses and minuses, I've been out on early in my career when I finished. I had the opportunity to go out to do some mission work, and so what I observed is people like me are really comfortable dealing with the higher risk surgical candidates. And so, at least back then when I still did pediatric anesthesia, gave me a child to anesthetize, I was quite comfortable with it. The GP anesthesiologists were a little more reluctant to take those cases because they, at least in what we were doing, not that GP anesthesiologists can't do pediatric anesthetics, but it was just the conditions where they were less comfortable with that, and that's understandable. But they were able to do a whole lot more other things. If we needed someone to, do non-anesthetic tasks, they could jump right in and do them. So in one place I went, we were doing a lot of eye surgeries, and the GP anesthesiologists could also do the ophthalmology exams credibly. And I remember one day when the exam room was really busy, and the ophthalmologist pulled me and said, "I'm going to give you a crash course on fundoscopy because I need another person." I was really not a good choice for that. Okay, and that's the difference. Okay, so I think, if I could do it over again and say I couldn't do anesthesia, I probably would have gone into GP anesthesia because it gives you a different skill set that is sort of portable across the world in some way.
And along that vein, is there anything looking back on your career that you had wished you had known when you started? Or anything you would have done differently?
I think a lot of those I've spoken to medical students about. As I said, I'm pretty open about sort of some of my mental health problems. And I think some of that goes back to that lack of appreciation of the skills that aren't related to content, not medical content, and more of how to look after myself. How do I view myself as a person? Do I tie my value as getting things right? And that when bad things happen, it's an indication that it reflects on me. Knowing when to ask for help, which, I think, maybe your generation laugh and say these are easy things, but for me it was asking for help seemed like it was an acknowledgement of failure or you're weak, and they're not, okay? There's those sort of things. All the resiliency skills that you're being told are things I had to learn when I was much older. And also realizing that your career is a marathon. It's not a sprint. You don't need to accomplish everything in the first 5 years of your career or something. And sometimes you just have to be patient and move slower, or you'll burn yourself out, which is what I did. And I think even though I'm not, I wouldn't wish it on anyone, but developing a mental illness for me slowed me down and helped me see what I need to change to be able to balance my life better. Now, I can't say I'm a professional at balancing my life. I still have times of the year where there's too many things going. I still have a hard time learning to say no to people. I'm better, but I'm not. But these are the sort of things that, as medical students, you are already being told these things. And, we hope that some of it is sticking. Because maybe I had heard some of these things from my teachers when I was in medical school, but it certainly didn't stick.
I wanted to thank you for your advocacy and being so honest to us about some of the issues that you've dealt with. Because I think even though we are in a society that is evolving and changing, it's due to people like you who are sharing your story. So thank you for that. Over the course of your career, what's one thing that you would say should be the focus of any doctor, any medical student? I think it's really easy to get caught up in knowledge and content, but what is the focus, would you say?
I think the thing that's really helped me in my career, once I got over the idea that I needed to know everything, or I'm an imposter, which is a thing that I think all of us sometimes think we do, is realizing that even in my field, where my interaction with people is less, it's the relationships that is the most important thing. Medical knowledge will change over time, and yes, we have to continue to keep up to date. Technical skills are things you can acquire, but the things that are either fragile or firm is how you treat people. I think many of us came into medicine thinking we want to help people, and that's what started us on that journey. Sometime along the way, sometimes we get jaded, we get tired, we get caught up with other things, and it can be easy to forget that those relationships are the things that we have. That's where the energy comes. And I'm not just talking about patients, building the relationship with the patient and being able to try and look at the person and say, as much as this person is annoying me or driving me crazy because I'm tired or angry or whatever, somebody loved that person at some point in time. And if I can just grasp and say, can I see that person in the lens of saying, that they're still a human being, and in spite of my inability to feel that way, I still have to look after them that way. That helps me to try and be a more empathic or empathetic individual with those things. And I'm thinking of the one, like, there's always some people that you'll find you just don't find you could care for, and that's where that little twist. But the other thing is also your relationship with your co-workers. It's so easy for us in medicine to get so busy that we can't read the signals from our colleagues when things are not going well for them. Some of the joy of working in healthcare is when you can you have relationships with people, not just doctors, but nurses, might be the cleaning staff that works for you, all that, and being able to feel like that you know them and that you're working as a team, and that as a team you can accomplish something.
So my next question would be, do you think that there's a certain type of medical student that's best suited to anesthesiology? Or are the skill sets like staying calm in an emergency things that can be learned?
The nature versus nurture thing. And I think there's a bit of both. I'll tell you an anecdote. So I was at a leadership workshop, and one of the ones that they had was about self-awareness, knowing yourself. And one of the things they did is they give you these questionnaires to look at what kind of type of person you are. And all of us thought that surgeons would be a certain type, internists, like there's certain stereotypes. And what we found, and what they told us from having done this many times, is that people of all different types, all different natures, end up in specialties. So we have a stereotype of what we think is the typical person, but the truth is that you can be an introvert or extrovert. You could be someone who loves action, like dives right in, or someone who has to think about it to do it. You can be any of those and still succeed, okay? Because some of those things you're talking about are skills that you learn, you acquire. There are traits that may make it easier for you. So, for instance, in anesthesiology, we often comment that we tend to have, if we don't have them, we acquire them, obsessive compulsive traits. So we're focused on one person at a time, and we're very, very obsessed about details, paying attention to your blood pressure, heart rate, carbon dioxide, we're just like tweaking things, and that's certain traits that, if you come in as a medical student already in a rotation with those, we would pick up on those, and in a way it would be, whether conscious, subconscious, we would say, this person seems good for anesthesia, right? Anesthesiology, not for anesthetics. And that's probably because these are some of the traits that tends to help is you do have to be someone who likes to do things with your hands. You have to be comfortable that no one else is going to acknowledge you for what you do necessarily. So you have to have a certain ability to say to yourself and say, I did a good job, instead of expecting that other people are going to tell you. So there's little things, but a lot of this, again, you can learn. If you have those traits, you may find that particular, that our specialty is just seems to be more interesting. That's all it is. So I don't know, really whether people go in because they have the traits to start with, or whether it's because they found the specialty interesting and then they acquired those traits. I can say for myself that I've already had those obsessive compulsive traits before I entered anesthesiology, because they're also useful in internal medicine. I wasn't always comfortable with sort of the crises moments, or having to portray, like to be able to manage staying calm, but those things I learned to do over time. Yeah.
You talked a little bit before about the lessons you've learned along your career in terms of managing your own wellness. And I'm just wondering, do you have any advice for medical students who maybe at some point along their educational process might find themselves struggling with a mental illness?
I'm not in a position to offer advice to any particular individual. I think some of the things I've learned is that one is try and build a social support. In medical school, that depending on whether you have people around you, family and things like that, it might mean families. It might be friends either inside or outside medical school. You also develop friendships in medical school, and some of them are going to last a long time. And so those are some of the things that that social support is very helpful. I found being able to gripe with my classmates allows you a safe place to be able to sort of decompress. And it also means that if you do it then, it also means you're not talking shop all the time at home. Or if you have a party with your friends and your partners there, and that you sort of inadvertently exclude the person because every one of you is talking shop. And that's one thing I learned in marriage, is that you have to be very careful of that. So having those social support and time to be able to do that is very helpful. A harder thing to do, I think, is being able to recognize when you need help. And this is why I say relationships are so important, because you have to look out for each other. So in medical school, you see each other probably more than anybody else sees you. And if something's different about the person, as polite individuals, we often just feel like it would be intrusive for us to ask. And one thing I learned to do from my own experience, realize if someone's behaving in a way that's not typical, it doesn't hurt to ask and say, how are you doing really? Like, not just, hi, how are you doing, sort of, and walk by, but, or say, I noticed you were this, and this. Is everything all right? Because you may be the first person to ask that. And that's partly because it's sometimes when someone is experiencing those, that kind of stress, or having in a state where they're mentally unwell, one day it could be that person doesn't recognize it. It could be that person fears the stigma, or this person may be unaware that it's affecting what they're doing and think everything's fine, and go, well, if nobody's commenting, then it can't be that serious or something. Some of that again goes back to building that support. One thing I've told other people is there are people in my department who know that I have suffered from bouts of depression, and the ones that I trust, I can tell them that if my behavior changes, you need to tell me, because I may not realize that what I'm doing is different, and maybe I need someone to tell me, something is not right here. So those are some of the things I think for people who may have mental health problems, that support system and building in some of the checks are ways to help. Trying to find time to address one's own health needs is important too, and I cannot advise anyone about what any individual should do. You all have your own ways to look after yourself, hopefully. And if you haven't, then it's important to start in medical thinking about that. For myself, I had to get over the guilt that I don't need to work 10 hours every day. So if I need a bit of downtime, there may be an academic day where I say, okay, I can end the day early, take a little bit of time off, because I know at some point I'm going to be working on a weekend or something to do something. And so in the end, it all balances out. But maybe I need just this afternoon, I just need to decompress or something, and not feel guilty that I'm doing that. And trying not to let the inner voice tell you you're lazy or you're not pulling your weight. Now, I'm assuming, of course, that you are all hardworking, conscientious individuals and not in the category of someone who really isn't interested. But that voice is sometimes will come in and tell you, oh, you shouldn't really be taking this time off. You should be studying a bit more or something. And that's something you learn to have to negotiate.
Thank you. I think you offer a good perspective on someone who's farther along the process than we are, for sure.
So as we're coming to the end of the interview, I just wanted to end with one question, which is, what's something that you're really proud of?
I would have to say that the thing that I'm proud of is not about medicine per se. Medicine is a part of me, but it doesn't define me completely. And so the thing I'm most proud of is that I have a good, loving relationship with my wife. We just celebrated our 25th anniversary just earlier this year, and I have 2 teenage children who still enjoy talking with us and coming home and spending time with us. And in spite of adolescent changes, they're pretty good kids. And I think that being a father and a husband are probably the most important things that I would say are the accomplishments that I'm most proud of.
Are you saying that just because you know your family's going to listen to this podcast?
Not at all. No. I've thought about this very much, and this is the thing. I love what I do for a living, but it would be very different if I didn't have my wife and kids. Yeah.
Thank you very much for talking with us today, and I think I speak for everybody who's listening on the podcast that we really appreciate the time that you spent today.
Thank you. Thanks for having me.
Thank you so much, Dr. Choi.
You're welcome.
This has been a presentation of the UBC Medicine Learning Network.